Okay, let's unpack this then. That really familiar burn, the one creeping up after maybe a big meal, we often just call it heartburn.
Right, simple heartburn.
But what if it's like happening all the time, not just a one-off?
Exactly. That's where GORD comes in.
Today we're diving deep into that. It's a chronic condition, Gastro-Oesophageal Reflux Disease, or GORD. It underlies that feeling for a lot of people.
Mm-hmm.
And listen, for you, our listener, we've actually got your notes right here. Our goal is to take all this info you've gathered, sort of distill it down, make it really clear, make it stick for your revision.
Yeah, think of it as a focus session on your notes, but hopefully less like staring at a textbook and more, well, useful.
Definitely. No overwhelming feelings allowed here. So, GORD, let's start right at the beginning. What actually is it, according to these notes?
Well, fundamentally, GORD is a long-term thing. It's where stomach acid and sometimes other stomach contents too flow back up. The already reflex into the esophagus.
Okay, so back up the pipe, it shouldn't go up.
Precisely. And the main reason this happens is usually down to the lower esophageal sphincter, the LOS.
Right, the LOS, that's like the valve, isn't it? Between the stomach and the esophagus.
Exactly. It's supposed to stay shut most of the time, but in GORD, it's either a bit weak or it just relaxes when it shouldn't, allows that backflow.
And the notes say a little bit of reflux is normal. That surprised me.
It did me too, initially. But yeah, occasional reflux can happen. The problem with GORD is when it's happening, excessively or for long periods. That's when the acid irritates the esophagus lining.
Ah, okay. And that irritation leads to inflammation, esophagitis.
That's the one, esophagitis. And if that goes on, that chronic irritation can cause bigger problems down the line, like scarring or narrowing.
Which is presumably where symptoms like heartburn and regurgitation come from.
Yeah.
And chest discomfort.
You got it. Those are the classic signs that the esophagus isn't happy with that acid exposure.
So we know the LOS is the main sort of mechanical issue. But what makes the LOS act up? What are the underlying causes, the etiology?
Good question. So yeah, the primary cause is that LOS dysfunction. But lots of things can contribute to it not working properly.
Like what?
Well, anything that increases pressure inside your abdomen is a big one.
Like being overweight.
Yeah, obesity is a major factor. Also, pregnancy increases pressure, even just wearing really tight clothing sometimes.
Okay. Makes sense.
Then there are issues with the sphincter itself, anatomically. Maybe it's just not formed quite right or the muscle tone is reduced.
Right.
And another thing is core esophageal peristalsis.
Peristalsis, that's the muscle contractions that push food down, right?
Exactly, like a wave. If that wave action is weak or uncoordinated, stuff isn't cleared away properly, and reflux is more likely.
Okay, so pressure, the valve itself, and how the esophagus works. What about lifestyle?
Oh, lifestyle's huge.
Yeah.
Smoking is a known culprit. Alcohol, too. Fatty foods, coffee, they can all relax the LOS or increase acid.
So all the good stuff, basically.
Well, sometimes. Even just eating really large meals can do it.
Any specific conditions? The notes mention a few.
Yeah, things like systemic sclerosis, that's a connective tissue disease,
Mm-hmm.
and hiatus hernia, where part of the stomach pushes up through the diaphragm. That definitely makes reflux easier.
And medications?
Oh, yes. Certain meds are implicated. Tricyclic antidepressants, anticholinergics, nitrates, calcium channel blockers. They can affect the muscle tone of the LOS.
Wow, okay, so it's quite complex, lots of potential contributing factors.
It really is. But one thing the notes are very clear on, and it's important for your revision. H. pylori infection, that bacteria often linked to ulcers, is not related to causing GORD.
Okay, good distinction. So H. pylori out, lots of other factors in. Let's nail that one down. Now, who's most likely to get GORD? Let's look at the risk factors.
Right. Knowing the risk factors helps identify who might need closer attention or preventative advice.
So from the notes, the big ones seem to be obesity again.
Definitely.
Hiatal hernia, smoking, pregnancy, we've mentioned those. Then specific meds get another nod. Calcium channel blockers and nitrates. And diet again. Fatty foods, chocolate, caffeine, alcohol. It's a recurring theme.
It is. And then some other medical conditions like scleroderma and gastroparesis that's delayed stomach emptying.
Okay, quite a list. How can we, group these for easier recall? Any memory tips?
That's always helpful for revision.
Maybe something linking lifestyle and conditions. How about, OBESADE. Does that
OBESADE, let's see.
Obesity, bad habits like smoking, diet, alcohol, scleroderma, hiatal hernia, age, it gets more common as you get older, drugs, those calcium channel blockers, nitrates, and expecting pregnancy.
OBESADE, I like it.
Yeah.
That covers the main ones quite neatly. Could be useful.
Hopefully. So now we know the risks. Let's get into the nitty-gritty, the pathophysiology. How does it actually happen step by step inside the body?
Okay, so it really kicks off with that LOS malfunctioning. Like we said, it's weak, or it relaxes at the wrong moment.
All right, the faulty valve.
Yeah, so stomach contents acid, maybe some enzymes. Bile sometimes splash back up into the esophagus.
Which is not designed for that kind of stuff.
Not at all. Its lining is much more delicate than the stomach's. So this acid causes irritation, inflammation.
Leading to the symptoms, heartburn, regurgitation.
Exactly. And if this keeps happening, chronic exposure. That's when you risk the more serious complications. It's like a chain reaction, really, starting with that LOS issue.
Makes sense. But, okay, someone comes in with heartburn and chest pain. How do we know for sure it's GORD and not something else? The differential diagnosis.
Ah, yes. This is crucial because other things can feel very similar.
Like heart problems.
Angina. Absolutely. Angina is a big one to rule out, especially with chest pain. Then you can have heartburn just triggered by specific medications or foods, which isn't necessarily chronic GORD.
Okay.
Peptic ulcers, too, can cause similar upper abdominal pain. Problems with how the esophagus itself moves motility disorders.
Right.
Different types of esophagitis may be from swallowing something corrosive, or infections, CMV, herpes, candida, especially in immunocompromised people.
Okay.
Less commonly, but importantly, GI cancers need to be considered. And then there's non-ulcer dyspepsia, basically indigestion symptoms without an ulcer and esophageal spasm where the muscles contract abnormally.
That's quite a few possibilities. So careful history taking is key.
Definitely. Maybe an example question would help here for revision.
Good idea. Okay, how would you differentiate GORD chest pain from angina?
Okay, well, the triggers and relieving factors are often different. GORD pain is typically worse after eating, maybe when lying down, and often gets better with antacids.
Whereas angina is more likely brought on by physical effort or stress.
Right.
And relieved by rest or nitrates.
Exactly. Those patterns are really important clues.
Okay, so it can be tricky. How common actually is GORD in the UK? What's the epidemiology picture?
It's surprisingly common. The notes suggest somewhere between 10 and 20% of adults in the UK have it.
Wow, that's a lot.
It is. It affects all ages, but does tend to increase as people get older. And interestingly, it seems to be more common in men, maybe 2 to 3 times more common than in women.
Huh. Any idea why?
The reasons aren't totally clear, possibly hormonal factors or differences in abdominal fat distribution, but yeah, it's a noted difference.
And just general heartburn is even more common.
Right. Oh, yeah. About a quarter of adults get heartburn sometimes. And for about 5%, it's a daily thing. GORD is really a spectrum, from mild reflux symptoms right through to ulcers or strictures.
And it's not just acid. Bile can reflux too.
Yes, that faulty LOS can let bile back up as well, which can also be very irritating to the esophagus.
And this is interesting. The symptoms don't always match what you see on endoscopy.
That's right. Someone can have terrible symptoms, but a normal-looking esophagus, or vice versa. It's not always a perfect correlation.
Also worth noting that some drugs can directly cause esophagitis, so taking pills with plenty of water is important.
Good point. And the big one, really, is the link between chronic reflux and the risk of esophageal cancer. It's a serious potential long-term consequence.
Really highlights why managing it is so important. Okay, so what does it actually look like when someone has GORD? The clinical features, the signs and symptoms?
Well, the absolute classic is heartburn, that burning feeling in the chest, often rising up. Typically worse after meals, maybe better with antacids.
The pizza regret symptom.
Pretty much. Then regurgitation, that taste of acid or food coming back up into the throat or mouth. Not pleasant.
No.
Unexplained chest discomfort is common too. And sometimes dysphagia, difficulty swallowing, or just a persistent sour taste.
Those are the main ones. But there are atypical symptoms too, right? Things that might not immediately scream reflux.
Absolutely. Some people get chest pain that isn't related to their heart or exercise.
Yes.
Or epigastric pain, pain in the upper abdomen and bloating.
And respiratory stuff. That seems less obvious.
It does, but it's well recognized. Hoarseness can be a sign sometimes called cherry donor syndrome. Maybe a mnemonic for that. Cherry for a red throat. Donor like a loud cough. Could help you remember.
Cherry donor syndrome.
Chronic cough is another one. A significant percentage of people with a persistent cough actually have underlying GORD triggering it.
Really? Wow.
Yeah. And even asthma-like symptoms, wheezing, shortness of breath can sometimes be aggravated or even caused by reflux.
So from a diagnostic point of view, what are the big clues in the presentation that point towards GORD?
Well, that classic combo of heartburn after meals and acid regurgitation is pretty suggestive. Plus, having those risk factors we talked about, the OBESADE factors like obesity, hernia, age, smoking, family history makes it more likely.
And we need to watch out for red flags, too.
Always. Progressive dysphagia, difficulty swallowing that's getting worse, is a major one. Persistent bloating, feeling full really quickly, that lump in the throat feeling called globus, any signs of dental erosion from acid, bad breath, or just ongoing indigestion that isn't clearing up. These warrant closer investigation.
So often you can diagnose it clinically based on symptoms and maybe response to treatment.
Often, yes, especially in younger patients with typical symptoms and no red flags. An initial trial of treatment is common.
But if it's unclear or complicated or there are red flags, then investigations are needed.
Exactly. And the main initial investigation is usually an endoscopy, a gastroscopy.
Where they put a camera down.
That's right. To have a direct look at the esophagus, stomach, and the first part of the small intestine, they're looking for inflammation, ulcers, hiatus hernia, or signs of Barrett's esophagus.
Okay, what else?
A full blood count, FBC, just to check for anemia, which could indicate bleeding. A barium swallow might be used, especially if swallowing is difficult, to look at the structure and function.
And those more specialized tests, pH monitoring.
Yeah, 24-hour esophageal pH monitoring measures how often and for how long acid is refluxing into the esophagus. It's very useful if the diagnosis is uncertain after endoscopy.
Is that the gold standard?
It often is, especially if endoscopy is normal, but symptoms persist. There's also impedance pH monitoring, which is even more detailed. It picks up non-acid reflux, too.
And manometry.
Esophageal manometry measures the pressure and coordination of the muscle contractions in the esophagus and the LOS function. It helps rule out motility disorders that could mimic GORD.
And you mentioned grading systems during endoscopy.
Yes, the Savory, Miller, or Los Angeles classifications. There are ways to grade the severity of any esophagitis seen, from mild redness to severe ulceration. Helps guide treatment and track progress.
Okay, so what's the typical investigation pathway?
Usually step one is that trial of medication, typically an 8-week course of a proton pump inhibitor, a PPI.
Like omeprazole.
Exactly, omeprazole, lansoprazole, those kinds of drugs. They reduce stomach acid production. If the symptoms get significantly better, that strongly supports a diagnosis of GORD.
And if they don't improve or if there are concerns?
Then you move to investigations, usually an upper endoscopy, the OGD, first. Depending on the findings or symptoms, you might consider manometry or pH monitoring. Capsule endoscopy is another less invasive way to view the esophagus sometimes. Barium swallow if dysphagia is prominent or endoscopy is impossible.
Key things to remember for revision about investigations.
Remember, symptoms don't always match endoscopy findings. Know the indications for endoscopy age over 55 with new symptoms, alarm features like dysphagia or weight loss, persistent symptoms despite treatment. And that 24-hour pH monitoring is the gold standard if endoscopy is inconclusive.
Got it. Okay, so we've investigated, we've diagnosed GORD. How do we actually manage it?
It's usually a combination approach. Lifestyle changes are fundamental for everyone.
I have to keep coming back to those.
Because they really can make a difference. Weight loss, it's overweight, definitely. Elevating the head of the bed for sleep, just using blocks or bricks under the head and legs.
Simple but effective.
Can be, yeah. Dietary tweaks, identifying and avoiding personal trigger foods, and avoiding meds that might worsen things if possible.
Then medications, PPIs seem key.
They're the mainstay, yes. That initial 1-month or more often 8-week course is standard for reflux symptoms. If H. pylori happens to be found, it's usually treated unless the person already has known GORD treating it, then can sometimes worsen reflux, oddly enough.
Holy.
For long-term control, often a step-down approach is tried reducing the PPI dose to the lowest effective level. Some people need long-term maintenance therapy, but we do need to be mindful of potential long-term PPI side effects and weigh the risks and benefits for each person.
And surgery. Is that common?
Less common now with effective medications. It's usually reserved for people who don't respond well to meds, have significant side effects, or have complications like a large hiatus hernia, or maybe just prefer not to take long-term medication. Fundoplication is the main surgery, basically wrapping the top part of the stomach around the lower esophagus to tighten the valve.
Does it work well?
It can, but it has its own potential side effects, and long-term benefits compared to medication are still debated. There's also a newer magnetic bead band procedure, but it's more specialized.
What if someone just doesn't respond to the standard PPI dose?
Good question management problems. First, Check they're taking it correctly, usually 30-60 minutes before breakfast. You might try doubling the dose, switching to a different PPI, or adding an H2 receptor antagonist like ranitidine or famotidine, often taken at bedtime.
Okay.
Always aim for the most cost-effective PPI that works. And, crucially, refer if symptoms worsen or alarm signs develop.
So prescribing-wise, initial 8-week PPI course. If it works, continue a lowest effective dose. If not fully working, optimize or add an H2 blocker.
Broadly, yes, often guided by specialist advice for resistant cases. And non-prescribing. Always push the lifestyle advice: weight, head elevation, avoiding late eating, surgery for specific cases.
And NICE has referral guidelines.
Yes, based on specific symptoms, red flags, age, risk factors. Importantly, endoscopy isn't always needed if there are no alarm features and the PPI trial works well.
Good to know. Oh, and stopping PPIs can cause rebound symptoms.
Yes, definitely. Acid production can temporarily surge, so weaning off slowly is sometimes advised if stopping. And prokinetics drugs to speed up stomach emptying aren't generally recommended for GORD itself.
Right. And those endoscopic grades we mentioned, Savory Mill or Los Angeles, they help track severity and treatment response.
Exactly. Higher grades might mean more intensive treatment or closer monitoring is needed.
So overall, what's the outlook, the prognosis for someone with GORD?
Generally, it's good with proper management. Most people can get good symptom control with lifestyle changes and GORD medication. Quality of life can be significantly improved.
But it's chronic, right? It doesn't usually just go away.
That's right. It often requires long-term management. And there are those potential complications if it's not well controlled. So adherence to treatment and regular follow-up are really key.
Which brings us neatly to those complications. What are the main risks if GORD isn't managed well over time?
Well, ongoing esophagitis, the inflammation itself, is the immediate issue.
Oh.
Chronic inflammation can lead to scarring and the formation of strictures, narrowing of the esophagus, which causes difficulty swallowing.
Okay.
Then there's Barrett's esophagus. This is a really important one. It's where the normal lining cells of the lower esophagus change and start to resemble the lining of the intestine.
And that's bad because
Because it's considered a precancerous condition. It significantly increases the risk of developing esophageal adenocarcinoma, a type of esophageal cancer.
Right. So long-term GORD is a major risk factor for that cancer.
It is. The longer you've had GORD symptoms, and the more frequent or severe they are, the higher the risk of developing Barrett's. This is why monitoring, sometimes with regular endoscopies, surveillance, is so important for people with Barrett's or severe long-standing GORD.
Okay, that really clarifies the importance of taking GORD seriously.
Absolutely. It's not just about discomfort. It's about preventing these potentially serious long-term consequences.
So, wrapping up our deep dive into your Glorden notes for revision, we've seen it's a chronic condition, usually from a dodgy LOS letting acid back up, causing heartburn, regurgitation, and other issues.
We've looked at all the contributing factors: lifestyle, anatomy, meds, the OBESADE risk factors, and the step-by-step pathophysiology.
Talked about how to tell it apart from other conditions, how common it is, all the ways it can present typical and atypical, even cherry donor.
Cover the investigation pathway, starting with that PPI trial, then maybe endoscopy, pH monitoring, and the management: lifestyle first, then PPIs, sometimes surgery.
And highlighted the generally good prognosis if managed well, but also the crucial need to prevent complications like strictures, Barrett's, and ultimately cancer risk.
Hopefully pulling all that together from your notes makes it clearer and easier to recall.
Yeah, I really hope this distilled version helps it all click for your revision. And remember, if you want more practice questions and resources for the MSRA, definitely check out passthemsra.com.
And freemsra.com too for, well, free resources. Always good.
Always good. So, a final thought to leave you with. Considering GORD is so common and chronic, what do you think are the biggest challenges in actually getting patients to stick with long-term management, especially the lifestyle stuff, to prevent those complications down the road? Something to mull over?